Thank you very much. I will not be sitting here asking for any funding allocation, I can assure you. My name is Dr. Jeffrey Lozman. I'm an orthopedic surgeon here in Albany. I'm professor of orthopedics at Albany Medical Center, so I'm very familiar with this area. And I'm here today serving as president for the New York State Society of Orthopedic Surgeons. On behalf of the New York State Society of Orthopedic Surgeons and the 1,600 orthopedic surgeons that we represent, let me thank you for providing us with this opportunity to present our views on the sweeping changes to the workers' compensation program as proposed in the governor's budget. The New York State Society of Orthopedic Surgeons maintains a specific focus on improving access to care, promoting public health, and facilitating improvement of patient safety and quality of care. It is estimated that employers spend as much as $15 to $18 billion a year on direct costs for musculoskeletal disorders, related workers' compensation, and up to 3 to 4 times that much for indirect costs, such as those associated with hiring and training replacement workers. A United States Department of Health study showed that from 1996 to 2004, managing musculoskeletal disease, including lost wages, costs an average $850 billion annually, making it the largest workers' compensation expense. For employers paying workers' compensation claims, the economic strain has reached the tipping point. 80% of all claims under workers' compensation are musculoskeletal sprain, strain, injuries, with low back injuries consuming more than 33% of every workers' compensation dollar. Back pain causes more than 300 million bed days and 187 million lost work days yearly from a review from the Department of Labor. Nearly all orthopedic surgeons treat workers' compensation patients. New York State Society of Orthopedic Surgeons believes that properly designed and efficiently run workers' compensation managed care programs can provide high-quality health care to injured workers and minimize their disabilities. The proposed changes in the governor's executive budget seek to ensure the system provides more timely and appropriate medical and wage replacement benefits to workers. While we support these general concepts, we are concerned several of the proposals will result in broad authority to the Workers' Compensation Board in decision-making without oversight and continued marginalization of physician participation in the program. This type of shift has grave potential to negatively impact access to care for the injured worker. The proposals of specific concern include provisions that would expand existing categories of healthcare providers to non-physicians, create an authorization agreement without specification, remove the role of medical societies not only from the approval process, but for removal of providers from the system, and extend the opt-out period from employer-selected preferred provider organizations from 30 days to 120 days. The New York State Society of Orthopedic Surgeons represents orthopedic physicians who best serve injured workers with the highest quality of care and provide easy accessibility. According to the American Academy of Orthopedic Surgeons, musculoskeletal injury accounts for 30% of all workplace injuries, requiring time away from work, and is the leading cause of disability claims. Orthopedic surgeons enable injured workers with sometimes devastating injuries to return to the workforce, improve and restore function, and foster active lives. Studies have shown that early intervention by the specialist, the orthopedic surgeon for musculoskeletal injuries, decrease the overall cost of care by allowing the musculoskeletal expert to develop a treatment plan that may or may not involve surgery. Studies also show that delays in direct appropriate care can result in high percentages of patients not returning to work, essentially increasing the cost to overall system. The proposed executive budget would now define providers in the system to include acupuncturists, chiropractors, nurse practitioners, occupational therapists, physical therapists, physician assistants, podiatrists, psychologists, and clinical social workers. Clarification as to how these non-physicians will coordinate with other practitioners when these patients are in need of specialized care is crucial. The proposal would permit these non-physician providers to render treatment and offer opinions on issues such as causal relationship of the injury to the accident level of disability. These non-physicians will serve as independent medical examiners having the ability to contradict the recommendation of the injured worker's treating physician. There is no clarity as to how this broad expansion of non-physician providers will benefit patient care. Rather, it leaves tremendous uncertainty as to how these non-physicians will coordinate patient care delivery and only dilutes the care received by the injured worker. The proposal goes on to expand the Workers' Compensation Board's authority with the creation of an authorization agreement, which will cause steep fines to physicians who do not follow the proposals. We have significant concerns this type of broad authority may result in unilateral decisions not in the best interest of the patient or the treating physician. This centralization of power, in concert with the imposition of the board's medical treatment guidelines, relegates the care delivered to these patients and ultimately marginalizes the role of the physicians.
And Doctor, because you're at 0, if you could just summarize the remainder of your testimony?
I would be very happy to do that.
Thank you.
What we see in the treatment of these patients is that the time that is allowed for their treatment in the physician's office is more than double any other type of treatment of the patients. In fact, in some physicians' office, 40%, it's even more than doubled. That the budget concerns that we have right now are significant. We have polled all of the orthopedic surgeons by a survey in New York State. We've proposed to them options that they can select from that deal with the new proposed fee schedules, that deal with the things that I've just addressed. 82% of the orthopedic surgeons in this state have responded by saying they will cut down significantly the number of workers' compensation patients that we see. We've received a tremendous feedback, both in my position and the position of our executive director, Babette, who's sitting next to me, from orthopedic surgeons in the state in the form of phone calls. How do I resign from workers' compensation? To just jump to the end, if I may, we strongly recommend reforms that preserve access to the physicians most qualified to care for injured workers. We do not believe that the New York State Workers' Compensation business reengineering process has addressed these concerns between orthopedic surgeons and other stakeholders. The orthopedic community throughout the state has spoken in no uncertain terms. We fear the proposal will result in access to care issues and poor quality of care. This is the very opposite of the workers' compensation mission and all that has been invested in the interest in getting the injured patient back to healthy, active, and productive lifestyle. I'm not here to be a fearmonger. I'm here to inform you that I believe the direction we're heading is not safe for patient access, for patient quality, for patient care.
So I think that you ended up in this hearing because the labor hearing, which would deal with workers' comp, had already come and gone. I just want to let you know that I represent the east side of Manhattan, and shockingly, there are some doctors who live in my district also. And I had received an email, very parallel concerns today, and had forwarded on to our healthcare ranker and our labor ranker and staff. So I know that we're actually looking at this issue. So I appreciate your coming and testifying, even though perhaps some people in the audience aren't quite sure why this is in this hearing today. So I want to thank you.
I can't answer that last question as to why it's in the hearing today either, but that's where we were placed. And we
Fair
felt
enough.
important
And this
enough
is
to
the
be
last
here.
hearing, so frankly, it's the only place anybody who wanted to get our attention was going to get it, but I wanted to assure you that I moved it along to the labor staff and senators and the health care policy people as well.
Thank you for listening and paying attention. Appreciate it.
Thank you.
Thank you.
Thank you very much. Our next testifier, Hillary Stuchin of United Jewish Appeal, UJA Federation, and I probably destroyed your name, so you'll correct me.
Actually, you got it quite right. So, and you're one of the few, so thank you.
Just luck.
So thank you for allowing me to testify today. My name is Hillary Stuchin, as you said. I'm the Senior Advocacy Advisor with UJA Federation of New York. In case you don't know, UJA Federation of New York is one of the nation's largest local philanthropies. We have a network of over 80 nonprofit organizations and agencies that serve New York's most vulnerable individuals and help build communities. Considering the length of how things have gone today, I'm just going to draw attention to a few things, mostly the needs of aging New Yorkers and proposed programs to help combat poverty, health, and social service issues affecting this population. I'll start with an issue that you may have heard about already today, NORCs and neighborhood NORCs. So New Yorkers are aging, and an increasing number of residents will require special health and social services facilitated by these naturally occurring retirement communities, as well as the neighborhood NORC model. These vital programs and resources help enable low and middle income New Yorkers to age in place, to thrive in their communities, and to delay hospitalization, assisted living placement, or nursing home placement. The programs and services that NORCs provide support a group that we really think might otherwise fall through the cracks. And in our conversations with directors of these programs, we learned that the resources that they provide, many seniors have come to rely on them. This includes case management, socialization programs, social worker assistance, transportation services, shopping assistance, and basic health services. This again allows seniors to remain in their homes and greatly improves their quality of life. In this year's executive budget, we've been provided with level funding for the NORC and Neighborhood NORC program. And while this is great, it is only $2,027,500 for each program. Worse than this, we're very concerned with new language that intends to cut funding by an estimated $951,000. And this is to programs that are really vital and successfully serve seniors and allow them, again, to age in place. We recommend that at a minimum, the executive budget terminate these, that the language in the executive budget terminating these contracts should be either excluded from the final budget and also seriously reconsidered. We feel that it's essential that the state adopt significant changes to the elder law, and this includes a review of the program demographic and density requirements and an increase in funding statewide to $10 million. This is $5 million for the NORC program and $5 million for the neighborhood NORC program. This will better serve this vulnerable and aging population. These changes will actually more adequately finance the existing programs and increase eligibility for essential services like this throughout the state. The intended program cuts evaluate the NORC programs based on, as I said, out-of-date density and demographic requirements. The current elder law hasn't been reviewed for the past 20 years. This is something that we urge you to consider. This means that programs whose numbers do not meet these statutory requirements, even by 1 or 2%, have their contracts terminated at their next renewal date. And this proposal is estimated to affect a substantial number of the NORCs throughout the state. Instead of taking funding away from existing services, we urge you to be focused on meeting the needs of your seniors and expanding services for this ever-growing cohort. The next item I'll discuss is actually a new funding request, and that's the Survivor Initiative for New York State. New York State is home to nearly 60,000 Holocaust survivors. This is just over half of the 110,000 survivors in the United States. And while the majority of this population actually does live downstate, New York City in 5 boroughs, Long Island and Westchester, we've actually found in our discussions that the Mid-Hudson Valley, Western New York, and Central New York regions also house a significant group. According to the Claims Conference, just the general definition of a survivor, a Holocaust survivor, is a person, Jewish or non-Jewish, who was displaced, persecuted, or discriminated against due to racial, religious, ethnic, and political policies of the Nazis and their allies. In addition to the former inmates of concentration camps, ghettos, and prisons, this definition includes, among others, people who were refugees or who were in hiding. Survivors experience complications beyond the normal scope of aging, and the needs of this group can actually be more complex than those of the senior community at large. They live with the aftermath of trauma and experience higher rates of depression, anxiety, and distrust of others. They have experienced childhood malnutrition and inadequate medical care growing up, and as a result, they have brittle bones, poor oral health, and other health issues. Some actually will not shower, and many do need to keep food close by at all times. Many survivors live in poverty, subsisting on fixed incomes that do not adequately cover the cost of care or basic necessities like housing, food, and utilities. We found that New York survivors, many of them live 200% below the federal poverty guidelines, and nearly 35% cope with chronic illness and require assistance. I see I'm out of time, so I'm just going to get to the ask. We request that following the support of both the federal government and the New York City Council, we hope that the legislature will fund the Survivor Initiative at $4 million. This will provide funding for specialized case management, caregiver training, mental health services, transportation services, socialization, and legal services statewide, as well as end-of-life care. These critical supports enhance the quality of life for Holocaust survivors as they live out their remaining years. Thank you.
Any questions? I want to thank you for your testimony. I do have one question. It's not within your testimony. I think I read a story today that UJ Federation is trying to get $40 million back from FAGS, which went out of business. Do you know any details about that?
I can't speak to that, but I can bring the question back with me.
Thank you very much.
Absolutely.
Thank you for your testimony.
Thank you.
Thank you. Next to testify, Gerard Wallace, Director, New York State Kinship Navigator. And following, for people getting lined up, Yolanda McBride, Children's Aid Society, followed by Kate Breslin, Schuyler Center. Thank you. Good afternoon.
Good afternoon. Thank you for the opportunity to speak. I noticed that Assemblywoman Will Pardo was here before, and I want to express my gratitude to her for the good work that she's done in the past 2 years in getting $1 million added for kinship funding. And Senator Montgomery was here, and she was way back in the heyday of kinship funding in 2009-10 when we had a grand total of $2.9 million for the kinship population. And Senator Savino, who has always been a friend and a champion of kinship care. Kinship care.
The three of us.
I know. What wonderful people. I'm sure you're all supporters, okay? I'm Gerard Wallace. I started in kinship care in 1997, first at Albany Law School, then Hunter College. Since 2006, I'm the director of the Kinship Navigator Program, the only statewide program serving this community, funded in the governor's budget with $220,000. I've had a federal grant for the past 3 years where the Center for Human Services Research has done a lot of surveying and studies, and I'm going to be referencing some of their data as we go forward. I also will try and cite to the page in case that's helpful if someone wants to look at the graphic, okay? Kinship care, grandparents, relatives, raising kids, even family friends. It is not foster care. To associate it with foster care is to really misrepresent and do an injustice to the kinship population. Estimates, page 6, 150,000 to 250,000 children. The census data there shows 218,000 kinship families. We really don't know, but the number is huge. Kinship care causes. Causes are in the literature: abuse, neglect, abandonment, mental illness, incarceration, death of the parent. These are the causes that are very similar to the reasons that children could be in foster care. The informal kinship population that I'm referring to is a child welfare system. It just happens to be one that isn't funded. On page 13, part of our survey, the Center for Human Services Research has a table there of the causes of kinship care. You'll note that the two largest causes are mental illness of the mother, and the largest one is Child Protective Services involvement. Clearly, our children are similarly situated to children in foster care. On page 14, in another part of our survey, in a cohort data mining of child welfare data in 5 upstate counties, of the 459 children, 86% of them had CPS investigations. Clearly, our children are similar to children in foster care, but they are not in foster care. Kinship caregivers, their circumstances: clinically high levels of stress, 40%. Trauma and loss. I have Center for Disease Control data in here showing that the ACE study, the Adverse Childhood Experience, these kids have those experiences. And poverty. The study that we have in the federal grant, 40% poverty rate for families upstate. These families are in tough shape. Now, the worst thing we hear, This Child Protective Services gave me this child 8 years ago. This is the first time I found out there's help. That's what our programs do. We're the only outreach out there. What are our programs? I'm the Kinship Navigator. The Kinship Navigator information referral, a warm line, a website with a lot of resources on it, advocacy, legal assistance, and policy work. Local kinship programs funded by the good work of the legislature, 13 programs serving 17 counties. Some of the counties left out, for the benefit of the chair: Bath, Jamestown, and elsewhere in the state, Dutchess County, Poughkeepsie, and all the mid-level municipalities upstate are left out of this situation, and yet they are suffering tremendously, particularly along the southern tier with the opium epidemic, the heroin epidemic that's going on. We deserve to do better for our kinship families. We can do better to them by providing the small asks that we have. The Kinship Navigator wants to implement in the 45 counties that it is the only resource, techniques that it learned in its federal grant that increase referrals from DSSs by 600%. We want to collaborate in those counties. And the local programs, we deserve to have more, and the ones that are there deserve to have more too. You'll see in the literature, in my recommendations, what our ask is. One other ask that I'd like to highlight is we need the legislature to be more involved in the kinship community. Whether it's hearings, whether it's roundtables, whether it's funding a study, this huge population is so badly served and in such dire straits, they deserve better attention, for us to look at the reasons why Child Protective Services is giving kids to relatives and to look at what we can do to serve them better. I'm out of time, okay? Thank you.
You did a lot in that very short period of time.
Thank you, okay.
Senators, Diane Savino.
Hello, Jerry, how are you? I'm just curious, do you have, how many children in the state are living in kinship, not kinship foster care, but, not kinship foster care, living with relatives that are not, where the children aren't in foster care? Do you have a sense of
I would say, yes, the numbers range. NEKC estimates 153,000 children in kinship care, of which they say 5,000 are in foster care. We know the number in foster care, which is an approximation because the data is bad, is under 6,000, but the range upward, you can go from a low of 153,000 to other estimates over 250,000 children living with relatives. And again, this is a snapshot in time. 1 in 10 of all children will live with relatives during their childhood.
And because these children aren't in foster care, you don't have court order over them, you don't have foster board rate. We may have court-ordered supervision, I guess.
Article 6.
Right.
And there may be some direct custodies, which are Family Court Act 1017 outcome. Right. But for the most part, they've either gotten it on their own. Erie County is a good example where lawyers up there tell me that the county gives children to relatives and then cuts ties, and they wind up in the legal service arena up there.
That's how we wound up with kinship foster care to begin with. There was a landmark lawsuit brought against the city of New York.
I'm sorry?
That's how we wound up with kinship foster care to begin with.
Only if they come into care and are subject to an Article 10.
Right, but if you
recall... They're not subject to Article 10.
I know that, Jerry, but 30 years ago, this was the subject of a huge lawsuit against the city of New York. Because at that time, the child welfare worker, the protective services, would take children, drop them off with a relative, and leave them there and provide no support services, no judicial oversight of the case, actually no service plan whatsoever. And that led to a lawsuit against the city for not providing children with relatives with the same level of services as children in traditional foster care.
Well, the same level of services is the key. If they're in the system, they have to get the same level of services. What I'm portraying here is they don't get in. And that's what our data in our federal work backs up. So that's the distinction. The distinction is they're not in the database, they're in the child CPS record, the case record that goes no further than the desk of the CPS worker. No one understands or can give a real estimate as to how much of this is going on. But we hear it anecdotally all the time.
Oh, that's outrageous.
It is. It truly is.
We should, well, you know, We've had a long relationship, and I think we should probably talk more about this post-budget.
Yeah, really, the investigation by the legislature into this practice, and I would say on both sides, CPS wants to do the job right, they're overwhelmed, kin are a resource, the counties are strapped with money, you know, depending on the county you're in, there are wholesale practices to use kin on the cheap.
But foster board rate is predominantly reimbursed by the federal government.
Administrative costs, court costs, you know, caseloads, and it's gone.
I'm just going to follow up on Diane's question. So why do you think you end up in a better situation if you get pulled out of foster care eligibility and moved into adoption subsidy category? Well,
that's kin gap. Kin gap,
Right.
again, applies to that small sliver of foster parents who are kin. The kin gap report has not been released by the governor, but my last one I saw, which is at least 2 years ago, there are less than 2,000 kin gaps done in a year, kinship guardianship assistance program. And the counties resisted it when it was enacted because they were using the same money from the social services block grant that they had to use for other purposes. So the idea is they would be more willing and there would be less roadblocks to kin exiting foster care as guardians with that grant if the funding stream was part of the adoption subsidy. That's all well and good, and we support that. My emphasis here is to say that's missing the target. Okay.
I guess I've been here in the Senate for about 14 and a half years. Before that, I spent 20 years in direct service. And at that time, even up to, say, the year 2000, what we would see in the city of New York, despite the court case that Diane is correct about, would be the grandparent or other relative would take the child because mom, dad went to jail, went to psychiatric hospital, were incapable of caring for them. The adult would eventually come and say, I can't afford to keep this child, I can't afford the rent with additional child or children, help me. They would be advised, go on, add the children to a public assistance case.
Right.
When that was inadequate, because it was, they would say, I heard a rumor I could be eligible for something called kinship foster care.
Yeah.
And they would be told, you have to say you're giving up the kids unless you get the kinship care. And if you threaten to give up the kids, we'll determine you aren't qualified to be the kinship adult.
That practice continues.
Therefore, it's a lose-lose. And we used to have to fight that day and night. And you're telling me nothing has changed 15 years later.
I'm telling you that the practice of surrender, the threat by some counties is you'll never get the kid back. And there are many ways in which they dissuade families, kinship families, from wanting to be in foster care. And I've written papers on it. I've written one recently for the Child Welfare League of America on these practices. And I'm saying everyone's overwhelmed. We need to make better decisions about who gets into foster care and who doesn't. And the only way to do that is to get good assessment tools and to put in place good practices for CPS to at least figure this out and not worry about mom sneaking in the back door and doing something crazy because they dumped the child and there's no oversight. You know.
So I know that OCFS happens to still be in the room, so consider this a request that OCS come and visit myself and any other senator who would like to join us to explore why we're still hearing the same stories 15 and 20 years later statewide.
Yeah.
Thank you very much for your testimony. Any other? No. Thank you for your testimony.
Thank you very much. Thank you.
And our next testifier, I think, is Yolanda McBride from Children's Aid Society. Is she here? Because we didn't see any testimony. Oh, somebody's coming down? No? Okay, goodbye, Children's Aid Society. You had your chance. Kate Bress.